Thanks for staying with us here on Sunrise. If you're just joining us, thanks for coming along for the ride. And welcome back, of course, to an important set of conversations that we will be having throughout the month of October. Happy Pinktober. Yes. We're celebrating the month of October under the theme, Pink is an action and not just a color. Now, the schedule your mammogram appointment today. Today, we are joined by co-founder of the Breast Oncology Service Clinic at KPH and consultant general surgeon at the Jamaica Cancer Society, Dr. Hugh Anthony Roberts, and who will be telling us about all the plans in place for this month.
Welcome, Doc.
Welcome.
Good morning. How are you?
Morning. Guys.
Nice to have you on the show. And I like your tie. Yes, the ode to the Pinktober.
Yes,
I'm loving it. But, Doc, I'm happy that we're talking about this morning because, you know, when October comes around, breast cancer awareness is, you know, at the forefront of the mind. And we want, and for both men and women, because men, too, can get breast cancer, right?
Yes.
And so we want persons to go and get their checkup. And I'm going to be scheduling mine in short order as well, because those things I find are very important because early detection is key. Talk to us just about, some people still don't think breast cancer is a big deal or a big issue. How concerned should we be? How prepared can we be?
I don't want people to be concerned to the point where they have paranoia and think about it every day and it becomes a problem affecting their daily life. But it is the #1 cancer amongst women, not only in Jamaica, in the Caribbean, in the States, in most first world countries, if you exclude skin cancers, especially in those Caucasian populations. So it's not only a phenomenon that exists among this region, but it's a worldwide problem amongst women.
Why is breast cancer so prevalent? I mean, with things like prostate cancers, you see it prevalent in, for instance, black populations, and there are, you know, different theories that have been presented. But breast cancer, why do you imagine it's so prevalent?
So one of the things I remember that you started with was talking about breast cancer not only in women, but in men. But unfortunately, the incidence, meaning how often it occurs in women, is way more. It's at least 100 times more prevalent than you see it in men. I've probably seen more than 2,000 women with breast cancer. I've only seen about 4 or 5 men in my entire career, and I think that speaks across the board with most general surgeons in terms of the ratio. We do know that breast cancer has a significant correlation to estrogen, which is obviously higher in women, but we can't say that estrogen causes it, because if that's the situation, then we know that everyone
would have it. Yes.
There are things that you just need to know in your history. Like, for example, if you have anybody else in your family that may have had breast cancer, that's a clue. You can do genetic testing for that, something that which we started doing at KPH more routinely as well since we started the breast clinic in October 2020, ironically. I must give a shout out to all of the other colleagues there, especially Dr. Copeland, who basically runs that clinic as well.
So pardon, Doc, that clinic was established in 2020.
Yeah, so...
Is it for the public? It's open?
It's at KPH, so it's public. So what we actually do is there's a focus clinic that was started. So let me make this categorically clear. Any general surgeon is trained to operate and manage breast cancer patients. And that's part of the training, not only in Jamaica, but across the world. But what we found is because of the incidence, meaning how prevalent it is in Jamaica and the incidence of number of new cases that we have every year, we decided that we're going to have a focus clinic, especially to deal with a lot of those patients that may have, sadly, advanced breast cancer. So we find that compared to first world countries, we have almost 3 times as many patients that present with advanced or late stage cancer, which is still somewhat treatable, harder, obviously, more difficult to treat. It means also that you probably need a lot more cancer regimes. So even though I'm a surgeon, the heme-oncologist who administers chemotherapy, the radiotherapist who gives radiotherapy, they are also heavily involved in patients, especially those patients that have advanced breast cancer. And then the biggest problem why we always try to promote screening, especially, you know, this Breast Cancer Month, is because when you looked at the cost of it, so even though, yes, healthcare in the public is free, not everything is necessarily available, especially when you're getting into some of the drugs. And if you speak to some of the companies that actually supply the drugs locally, even though they have a great program, like for example, Roche, I have no fight in this, they would have a program that subsidizes the cost. You're still talking about $300,000 for some of the drugs per dose.
Wow, per dose. And you need about how many doses?
Well, in terms of that drug, you actually have to have 18 doses. So you can do the math on that. And that's you know, it depends on what type, but you'll see those costs more rising in the more advanced stages of cancer.
Yeah.
We did a cost analysis, which I presented last year, after speaking to a lot of my colleagues, not only in terms of surgeons, but across the board, heme-oncologists. You are talking about somewhere between $3 and $5 million for stage 1 disease. These are absolute costs, right? Including surgical fees, which don't come into play in the public sector. You're talking about $3 to $5 million for about stage 1 disease, which is early breast cancer, versus you're talking about $14, $15 million for stage 3 disease, which is advanced cancer. And you have to also think about the mental stress, because when we're always talking about health, we talk about the physical health. The physical health is something that you can treat, it goes away, but patients still have to go through that mental journey.
Yes.
Right? So even though there's a cost difference, you have to think of where that money is coming from. So after that person may have received treatment, have survived, they still now have to recoup that cost. They still have to go through the mental stress, especially if it's one-sided breast cancer, which most women present with. Because even though I talked about the family history being a risk and those things, you have to also think about the fact that many women have 2 breasts. There's one breast that's affected. So it means the other breast is also going to be affected. They're going to be at increased risk for developing breast cancer in the other breasts later on in life.
Wow, Doc, it's a lot to take in and a lot to digest, but I'm happy at least there is help and there is a clinic that persons can go to get sorted out. But Walk for Cure is very important. Talk to us about that and how we, as citizens of Jamaica, can help to bolster and embolden your efforts.
Well, I think when it comes to the Cancer Society, and I'm not going to single them out alone, there are other entities that you know in the public and the private sector that have other ways of raising money, but also raising awareness for breast cancer. So I think that's the goal that you're trying to get across to everybody. It's nice that we talk about breast cancer in October, and there are other months scheduled for like colorectal cancer, prostate cancer, cervical cancer, even kidney disease. But even though we talk about this in October, which is the 10th month, we have to recognize that there's still 11 other months that this occurs. So we don't, even though we want to stress the message in October, we want that people are cognizant of what goes on for the other 11 months of the year, and it's not a forgettable disease. And then when August, September comes around, you're like, oh, great. Like it's carnival season. You know? It's something that's there throughout the year that people need to be cognizant about. I think you guys are obviously doing a good job. The media is doing a good job in terms of getting the message out there. You could always do more, but you have to also look at the privilege that we have that we can do something.
Right,
And
absolutely.
what I want to see is that every year that we speak about breast cancer, I can come and speak about something new that's happening in Jamaica. So for example, for years, we never had a mammogram unit in the public sector. We only have one now at KPH, and we also have one at Cornwall. So that's 2 versus 2 years ago where there was 0. So we've made strides. The problem is that those are only used for diagnostic purposes, because we do not have the manpower, and there's only one machine, and also to undergo screening. So screening is still taken up by the Cancer Society, which provides subsidized costs. There's a machine at university that also screens patients. I should also mention that the university is probably going to start a breast cancer clinic very soon, because they do have a surgical oncologist and more recently a breast oncologist, a breast surgeon that just came back. So they've actually been communicating with us to look at how we started. And we have very good relationships with university, so that's just dialogue. And they have even better facilities than us at KPH. They're obviously not fully public, it's going to be attracted to costs, but there are machines available in the private sector where people can get their screening. So it doesn't matter where you are.
Well, let me just ask, Doc, so somebody watching right now, and even for my own edification, you want to do a self-breast exam right now, right? What can we do? How do we do it?
So there are 3 parts that undergo in screening. So we talk about the mammogram, that's the last part, or the 3rd part. The first part actually is more so breast self-awareness. So we actually don't fully encourage breast self-examination, because that can lead to paranoia, more false detection. Like you're going to say, oh, I feel something. And then when you go to the physician or whoever it is, they're going to have to investigate it. What we want you to be is aware of how your breasts feel. This is where your husband also comes in, right?
You know, Doc, you got jokes.
Right? But all jokes aside, it is about you knowing how your breasts feel. You go in the shower every day. If you feel something that's abnormal, pay attention to it, especially if it's something that doesn't go away in a week or 2 weeks. That's when you should seek further treatment or investigation. The second part of it is what we call a clinical breast examination. So that doesn't have to be done by me as a surgeon. That can be done by your OBGYN that you're supposed to visit at least once a year, or even your family physician like your GP. And they're the ones, or even the nurse, if you have a occupational health nurse in your organization, they're experience in terms of doing that examination on you. And then once you pass those 2 stages, then you should then consider going for screening with the mammogram. And even though we do see an increased incidence or rise in breast cancer amongst younger patients, the actual age that we want to start screening at is 40.
Yes.
Right? And that's where you should be doing your annual mammogram. There are obviously exceptions to the rule for persons who may be higher risk. The problem that we have with the mammogram, even though we do have some 3D mammograms in Jamaica, most of the mammograms are 2D, is that as you are younger, the sensitivity or the pickup rate of mammogram in younger patients is less. And remember, screening is persons that don't have any symptoms. So in terms of if you find something, you would get a mammogram even if you're under 40 because there's something there. But in terms of screening, which means you don't have any symptoms, meaning you don't have a lump or anything, we only recommend that in the average risk patient at 40. Higher risk patients, as I said, we would treat them in a separate group and they may get screened at an earlier age.
And higher risk is by virtue of genetics?
Right, so if you have genetic testing that shows that you have a gene that may predispose you for increased risk of breast cancer, if you have a strong family history like a first degree or second degree relative, which is first degree is like your mother, your sister, second degree is like your aunt, right, or your grandparents. Those are examples as well. There are also some cancers that are affiliated with breast cancer, but again, that leads back to genetics. And then there are other things which are not necessarily as common nowadays, like, for example, if you had actual radiation to your chest wall, that may for some other disease. And then, as I said before, if you had a personal history of breast cancer, even though that doesn't really come into screening, that's more surveillance.
Right.
But those are the persons that we would look at and assess them as high risk, and then we would probably start screening in those family members earlier because they have a strong family history or something.
Doc, I know that our show is beamed all across the world, and I know that there are many Jamaicans who are overseas who want to give back in a tangible way to help our citizens. Breast Cancer Awareness Month is this month. How can persons reach out? So, you know, for somebody who said, Doc, I never know that they only have 1 machine or they only have 2 machines. I want to come together and get a machine or contribute to the purchasing of a machine. How can we get on board to help?
I think that you could always go through the Ministry of Health directly. And there's also the Jamaica Cancer Society, which has a huge role, not only for breast cancer, but all cancers. And just reach out. I think when it comes to those decisions, it's best that you figure out, because the Ministry of Health, as you know, their plate is wider than this room in terms of what they have to deal with. So I think reaching out to even individuals like me, I don't have a dog in this fight, meaning in terms of I'm here to treat and spread the word, but just reach out to anybody. Because main fact that the diaspora must know someone locally, and just having a simple conversation can help in terms of buying equipment, you know, drugs, etc.
All right. I love that, Doc. Well, thank you for all you do.
Thank you very much.
Thank you for the information. And I'm encouraging anybody out there who has the wherewithal, who has the resources, and would like to contribute, donate. Dr. Hugh Anthony Roberts, Consultant General Surgeon, Jamaica Cancer Society, we're all asking for all hands to be on deck. So we're not just standing by as, you know, officious bystanders, but we're really, you know, trying to put a lid on this. There are many women who are suffering, many men too who are suffering, and we definitely can help each other. So thank you so much, Doc, for sharing, and we wish you all the best. Our guest has been, as I mentioned earlier, Dr. Hugh Anthony Roberts, Consultant General Surgeon and volunteer at the Jamaica Cancer Society. TK is up next with the news right after the break, so do stay with us.